So we're going to be talking about seesaw nystagmus. And a seesaw, as you know, there's one person on this side and another person on that side, which means one person goes up and one person goes down. But in seesaw nystagmus, which is a form of torsional nystagmus, we also have the rising eye is going to intort and the depressing eye is going to extort. So we're going to have a rising intorsion movement and a depressing extorsion movement. And so that produces a characteristic seesaw morphology of the nystagmus. So seesaw nystagmus is a form of torsional nystagmus where we have elevation and depression, and we have intorsion, and we have excyclotorsion. So the eye is going to be excyclotorting and encyclotorting in the rising and falling eye. The localization of seesaw nystagmus is usually to the sellar or parasellar region. And so it's counterintuitive, but you probably should be doing a visual field on a patient who has seesaw nystagmus, because what you're looking for is the bitemporal hemianopsia of the sellar or parasellar lesion, usually a pituitary lesion causing this. So we're going to do an MRI scan directed at the sella. However, other localizations in the visual vestibular axis can produce seesaw nystagmus, including interruptions at the midbrain and the interstitial nucleus of Cajal, and the visual vestibular connection centrally can also produce the same nystagmus. However, in terms of localization, you should pick sellar or parasellar localization. The treatment is to treat the underlying cause, whether it's a tumor or stroke or demyelination. And if they have the etiology already established, you can use medical therapy for seesaw, but it's not usually that helpful. Clonazepam, gabapentin, all these different other medications for nystagmus in general have been tried in seesaw. The major thing you need to know about seesaw is that it acts like a seesaw, rising eye and intorsion, depressing eye and extorsion, and it localizes to the parasellar region.